Where did you go? 1 second. I'm trying to pull up the PowerPoint. There we go. All right, so today we're going to be doing two different chapters, one on hematological, immunological dysfunction, and then one about the child with cancer. Now that you do have a case study this week that is due, also you have NCLEX questions that are due. I've sent you information about your quiz 3 of last week. We're going to do that on a open week, which is going to be um, as I put down. Also, remember week 5, we've moved that around too. So I've given you the information so you can plan ahead and with your quizzes and what to worry about, okay? So let's start. So hematological, immunological dysfunction. Now, one of the things about this is we can evaluate that extremely simply by a CBC. Also, it's that history, that physical, the child, what they're telling you. Now, what does a CBC have that's important? It has white blood cells. It talks about infections or problems with infections. It talks about red blood cells, which talks about the oxygen and iron it carries, because that's what red blood cells do. So, no oxygen, no iron, you're going to be fatigued. And then the third one is your platelets. Platelets are part of your bleeding coagulopathy thing that you need for when you have a cut or you're bleeding, that it will stop. We know that poor iron in food is one of the big common things for low hemoglobins in children, especially toddlers, because they're so fussy and so picky on what they want to eat, right? And we know if we're seeing frequent infections, we're going to look at a white blood cell count. And of course, the bleeding is the platelets. So when we're looking at a child with these issues, number one, we need that complete blood count, the CBC, because that simple little blood test tells us a lot of different things about a child. Then you take the history, assessment, what the child's looking like, and hearing the parents say, "Yeah, my kid's tired. He's sleeping all the time. It's not normal. He's usually so active and la la la." We know one of the things about toddlers and young children is being so picky in what they want to eat. So, iron choices, green leafy vegetables. I mean, yeah, okay, toddlers are going to say, I don't know, but there's other foods that we can choose. If we're having frequent infections, it's talking about your white blood cells, and bleeding could be those platelets. So, the most common of all the anemias we know is your iron deficient anemia due to neutropenia. Okay, so what is anemia? Anemia is when you have a hemoglobin and a hematocrit. It's not where it needs to be. You don't have enough red blood cells. Now, what do the red blood cells do for the body? It carries oxygen, so I can breathe and I can be happy. And it carries iron, so I'm getting my nutrition, nutrition, nutrition. So if we don't have oxygen and nutrition, you don't have enough to be active and alert. You're going to be fatigued. Now, what is a normal hemoglobin for a child? Well, we know normals like that 12 to 14 number, but with children, 10 is actually okay, especially if we're talking about infants when they start to eat, and of course, your toddlers who don't want to eat. Infants, remember, mommy's blood goes away, and the baby now has to produce its own cells. And we know that takes time for that to be done. It is not uncommon to have a 6-month-old infant with a hemoglobin hematocrit 9. Now, should we do something about it? If the assessment shows they're alert, they're active, they have no signs and symptoms, it's normal. We expect it. Okay. Now, if we're showing symptoms of it, we're going to do, of course, the treatment for it. Now, as a nurse, you get a child in complaining of being fatigued. So, and you see them, they look pale, they look tired. So, we're suspecting anemia. What am I going to do as a nurse? I'm going to assess this right away and figure it out. And I can do that very easily by doing an apical pulse, because if you're anemic, the body doesn't have enough oxygen, doesn't have that iron. So what does the heart do? It says, okay, giddy up. Let me get some more beats in there. Let me get oxygen and nutrients to iron to the body, but there is none. So it keeps trying. So you have tachycardia. That tachycardia and anemia, if we don't treat it, that heart's going to tucker out and tire and go into cardiac failure. As I'm listening, this is what I'm doing for my first assessment. I hear tachycardia. That's suspicious. But I'm going to listen to that swooshing sound that would be with anemia. Why does it do that? Well, when you have a normal hemoglobin, all those vessels are packed tight. So it just flows through. You don't hear a thing. When you have anemia, you don't have enough cells. So these things float and bang off of each other, and you hear that going on. When you don't have enough oxygen for the body, you're going to be cyanotic. Also, you need oxygen and iron for growth. So you're going to see some decrease in growth. Now, in your book, you have this. And I like it because it shows the three different types and way you can have anemia, whether you're not producing enough, you're losing it, or they're being destroyed really quickly. So let's look at decreased red blood cell production. We see that with nutritional things, that iron deficient anemia, B12 deficiency. So we can fix it by giving them B12 and iron, right? Sometimes it's a bone marrow failure. That means you're not producing the cells the way you need. We see that with aplastic anemia, and that's all cells, white cells, red cells, and platelets. So that's a big type of anemia. Also, leukemias. Leukemias can cause all of those things, also not to produce the way they should. Increased cell loss could be due to just overt bleeding, like an epistaxis. A nosebleed can tell us a lot. I've seen epistaxis in many children diagnosed something called ITP, idiopathic thrombocytopenia purpura. P for platelets, low platelets. Low platelets, they bleed, okay? So remember, white cells infection, red blood cells anemia, which is fatigue, and then platelets bleeding somewhere, okay? ITP, idiopathic thrombocytopenia purpura, is low platelets. I'm talking 20,000 and lower. What's the normal? 100,000 is your lowest you should see. They're usually 2, 3, 400,000. You need platelets to stop bleeding. It's part of factor 8, factor 9. Platelets is part of that cascade you need. Now, increased red blood cell destruction. We see this with sickle cell anemia, and we see this with thalassemia. And I'm going to go into what those are more intense as we go forward. And then, of course, we have the cell destruction. You're getting chemo. It's going to destroy cells, but it's destroying the bad ones, but it gets some good ones too. It also could be radiation, and overwhelming infection can eat up blood cells like crazy. So managing. Well, first you got to diagnose it. So again, a good history and physical. What's the kid been doing? What's the changes, etc. And a simple CBC. Yeah, there's a bunch of other ones you could put in there, but the CBC is always a start. So what are you going to do? You have a child, hemoglobin 7, they are fatigued, they're symptomatic, you're going to give them a transfusion. If they are iron deficient anemia, yes, if it's low, you do transfuse, but we're going to correct it with nutrition, or we're going to give iron medications for it. Now, as we're working this child up, we give an IV, okay, give support. We're going to just need fluid just to give some volume into the vessels. Also, a little bit of oxygen. Now, I'm going to tell you, I don't know if oxygen works. Oxygen needs red blood cells, and you don't have them. So, is oxygen therapy going to give more? This is a debatable thing. You'll see some physicians will give oxygen, some won't. But the biggest thing we can do for anemia as a nurse is to let that child relax. Cluster care. You don't want to overtax this child in any manner, any way. They have no reserve. So part of the assessment is how old the child is. It tells us clues and hints that racial, ethnic background. We know African American goes to sickle cell, Mediterranean, people from that area is thalassemia. So that will give us some hints what's going on. And then let's rule out the simple overt GI bleed. Take a stool for occult blood, rule that out. I mean, it's simple, do it. Another thing, with anemia, they're going to have to be going through a lot of tests, blood tests, follow up blood tests. So, again, prepare the child, decrease the stress as possible. Another thing, you got a child that's anemic and you need to do blood tests on them. These kids don't like things like that. So, decreasing their stress, making it less stressful, will decrease that child's anxiety. What happens if a kid's upset? The heart rate goes up, they're screaming, they're yelling, everything's blood pressure's up, and you're going to burn up any sort of oxygen iron that your body had. So try to make it as simple as possible, or you're going to have more problems. So iron deficient anemia is when you don't get enough iron in your diet. We know that children don't like a lot of these different foods, especially when we get to toddlers. In fact, we have many, many toddlers that are iron deficient anemic because of their inability to eat the stuff that they need, in a diet. Now, adolescents, they actually end up with iron deficient anemia because, oh, I'm too fat. I don't want to eat. I don't want to just drink a bottle of water. They don't eat properly. They're on the go. They're running. Too much other stuff to do instead of eating right. So those are the two groups that are higher risk. Infants need either breast milk or iron fortified formula. Sometimes parents think they can put them on regular milk. It doesn't give them all the nutrition they need. They need that iron fortified stuff. Now, milk, whole milk, may be introduced at 1 year of age, not till that point, okay? And that milk babies is that babies that were only given milk and don't get the nutrition, and that's what that is. So, what do we do for iron deficient anemia? Number one, we'd like to just have the child eat better. And if they don't, we're going to give iron supplementation. We're going to give either IM-Z-Track, dextran injections, IM, or we're going to give it orally. Do you remember how to give oral iron from pharmacology?
With a straw and with vitamin C, like orange juice.
Right. And the reason we give vitamin C is this. Iron, if you take it, needs the stomach acid to digest it, to break it down into some substance the body can use. And orange juice is acid. It helps that breaking it down and getting it ready. Nothing in your stomach, empty stomach before a meal, no milk. The other thing I'm going to warn you, tell the parents that the baby's stool is going to turn black and tarry. I've had an incident where a parent came running out to the nurse's station with a diaper with this black tarry stuff, freaking out, creating havoc because that baby stool turned what we wanted it, but the nurse didn't tell them. So the doctors don't tell them. You, please make sure you tell them, okay? So sickle cell anemia, we know if both parents have only the trait, you can have 25% of every child will have the disease. Now, I know you're either studying, have studied, or will study really soon in MedSurg 2 all about sickle cell. So let me try to explain it in a way that you can think of it and understand it better. Sickle cells are cells that are shaped like little C's, little sickles. And what happens as the blood flows through the body, it gets to these blood vessels that bifurcate, and the little sickle cell gets stuck. So it blocks the way so other cells can't go down. So, like a garden hose, if you kink it, if it can't go down, it's going to sit there and get big and go backwards. So that swelling is that inability of blood flow to flow past that area, and it's going to cause redness and pain and swelling. And the big thing is they hurt. Also, distally, they're not getting blood. So you could have some sort of cellular death. You could have problems. Let's say your toes start turning black because of bad circulation things. So, what do you think we need to do for this child? Now, this kid, sickle cell, one of the big why reason is dehydration. If you have blood vessels that are tiny, that could have been bigger, but you didn't drink, dehydrated, you had a fever, you lost fluids, you're out exercising, you're not drinking, your blood vessels are going to get smaller. And those sickle cells are going to get stuck. So dehydration is bad, bad, bad. Also, being out in cold weather, you need to be warming up the areas, keep it warm, let it be dilated, let blood flow through there. If you're going up in an airplane, you need extra fluids to keep more of the vessels open. If you're exercising, you need to get more fluid in you. Fever, you lose fluid like crazy. You have to make sure these children drink beyond that you normally do. And of course, if there's any trauma with a swelling, that's going to cause the problem too. So, how do we treat this? It's due to dehydration and little blood vessels, and you cannot get the blood through the blood vessels. So, what we need to do, we need to dilate these blood vessels. How do we do that? Priority treatment. You can treat the symptoms or you can treat the cause. The cause is little tiny blood vessels. So let's give some bolus of IV fluids. That's your priority. Now, I'm going to have pain medicine in my other hand because these children really hurt. I'm also going to put a hot pack on the area, vasodilatation. We know many times that sickle cell blood cells die quickly. So a normal hemoglobin on a child is low normally. I know that when I was working in the ER and I had a sickle cell crisis coming in, if I had a hemoglobin of 7, I would be happy. They can be 5 and 6. They come in wheelchairs, pale, head hanging. They just feel horrible. They have no energy, no hemoglobin. This is going to get a blood transfusion in the emergency room quickly. They need the cells, they need the oxygen for them to feel better. Usually, sickle cell crises are due to an infection. This is a concept I want you to listen to. Any immunosuppressed, any adult child, immunosuppressed, running a fever of 100.5 needs to seek medical attention quickly. Why? They have no immune system. They've got a fever. They need antibiotics now. They need to call the doctor. Okay. Now, children, young kids, they do put them on prophylactic antibiotics. And they start at an early age, 2 months to about 5 years, because They have no immune system yet. Remember, it takes up to about school age to get the viruses and this and that, and all the immunizations for them to be pretty robust in their immune system. So during that time, we assist them. Usually they give them something called PenVK, a little penicillin pill once a day. You will be monitoring the reticulocyte count just to see what's going on with it. And as I said, blood transfusions. Now, there's no cure for this. And our problem is they are immunocompromised. When you're immunocompromised, you get sick quickly. And that bacterial infections is a leading cause of death. They can live to a really good, age, but get an infection, call the doctor, and be really, really assertive on the care of yourself. So, early interventions when something's going on, if they have prophylactic penicillin, give it. Also, one of the things that can happen with sickle cell that we really don't think about is they can have a sickle attack in their brain, or maybe it's a stroke, because remember, their platelets are low, so that could happen. Also, worry about chest pain. It could be a pulmonary embolus. These two symptoms are priority when you're talking about sickle cell. Call the doctor, let them know immediately. These children, treat them normal, but you need to prevent the sickling. That would mean making sure they're well hydrated, that they have their fluids with them as they're outside. Or if they're sick, making sure they get it in. If they're going on an airplane, making sure they get fluids. If they're in the cold, making sure they're warm. All of these things can prevent. Now, thalassemia is a common genetic disorder of the Mediterranean descendants of the Mediterranean Sea. I call them rectangular shaped cell. The picture, you can see they look different. The problem is they burst. So the insides of the cell go out in the blood system. What are we concerned about? Oxygen and iron. So you don't have enough oxygen, so your brain doesn't get what they need. And also, they're not getting the iron is being spewed in the system, so they can become iron toxic. So they need treatment for that. Now, there are 4 types of thalassemia, but we always talk about the worst one, thalassemia major or Cooley's anemia. This is a child that requires transfusions. That's the only treatment, transfusions for them. When do we find out this kid has thalassemia? Well, we know babies are born with mommy's blood, and mommy's blood goes away. Somewhere about 6 weeks, we start seeing a change. Why would we draw a CBC on an infant? It's not normal. What would we see? They're not getting oxygen and they're getting too much iron in there. So you're going to see a child that's going to have some sort of developmental issues going on. You're going to see growth failure. The kid's not growing properly, and developmentally, they're not doing the milestones. And you will see that severe anemia. At 6 weeks of the cells bursting inside this baby, iron being spewed, and no oxygen. So treatment. Well, for the oxygen, we need to give some blood. We need to get them red blood cells that have some good stuff in it, oxygen in there. Now, the iron that's spewed into the blood system can create seizures and death. So we need to get the iron out of the body. So we can give an oral medicine, which is iron chelating desoxamine or desferel. It combines with the iron, grabs onto it, and you urinate it out. The other thing we could do is something called apheresis. And it's like a dialysis, but it just takes out the iron. You also can do apheresis to take out platelets or albumin or stuff. But in this case, we just want get rid of the iron because we don't want that toxicity, seizures, etc. So, what is our goal? What is our care management? Well, these children must be very, very compliant with their blood transfusions and chelation therapy. When do they get it? How often? Depends on the child. They're all different. So once a week, once a month, I don't know. They're all different. Okay. But they will need it and they need good follow-up. They need to make sure they're monitoring their lab values, their iron levels, etc. Think about the child and how much care they need. This is a family illness. Our biggest concern are complications from blood transfusions, blood transfusion reactions. So children can live to be adults as long as they're compliant with their care, blood transfusions, iron chelation therapy. But think about what the heart is doing when the hemoglobin is high with blood transfusions and then it goes low when the cells start dying. Think about what the heart does. When you get enough hemoglobin, the heart's happy and beats normally. But you know the body and the heart, it's like, oops, we don't have oxygen again. Let me beat harder. Let me beat faster. Let me try to get oxygen around to the body. There's no oxygen to give, but the heart keeps trying. Then you give a transfusion and the blood level comes up, and the heart beats fine. This up and down drives the heart nuts and can go into heart failure. That's one of the big complications. And then multi-organ thing can go on, of course, and they saying maybe a bone marrow can help. Now, aplastic anemia, I think, is the worst of all of them. It is pancocytopenia. That's what we talk about here. It is the red blood cells, the white blood cells, and the platelets. Everything on the CBC that you're going to look at. So you're going to have profound anemia, leukopenia, very low white blood cells, really apt to get infections, and thrombocytopenia. You're going to look out for bleeding. We treat this very similar to what we would do with leukemia, which would be that immunosuppressive therapy, maybe a bone marrow, chemotherapy. Now, let's look at bleeding problems, defects in hemostasis. Hemophilia. Now, hemophilia is a condition that's given to the children from mommy. It's an X-linked recessive gene that will give them hemophilia. Now, there are several types. And the reason you need to know is if you're bleeding, you need to give an infusion of a factor of what they're missing. Is it factor 8? Is it factor 9? Is it von Willebrand? These factors can be given to the child at times when they're bleeding. Children with hemophilia, we look at, where they're bleeding. But I think our biggest concern with hemophilia, especially with children, they fall down, they bump their knee, they get bleeding inside their knees, inside of joints. And bleeding in a joint is extremely caustic and could cause those joints to be deformed and then could end up crippling these children. So we want to keep these kids out of wheelchairs. So if they're bleeding in a joint, they need to give immediate care. Okay. Now, when we're trying to figure out, does this child have hemophilia? They do a whole list of meds, of lab values. Some are sent out, many of them, which take, maybe up to a week to get. But immediately we're going to get looking at a APTT, a platelet count, a PT, and these other things. And with that, we're going to have a good idea what's going on with this child. So in hemophilia, you have a prolonged partial thromboplastin time, APTT. That's just like heparin, right? We monitor APTT for heparin. It's blood thinning. That's what it's looking at. but you have a normal platelet count and these other things. So these are the initial tests that we could see that say, it's what it is. Once we get the labs back, we know what a lab factor is missing, we can replace it. Now, I'll tell you a story. I had a 9-year-old boy and his father came in one Saturday morning, and the kid had fallen down and his knee was swollen and ecchymotic. And they tried to call the hematologist, but they weren't answering. So they're like, no, we got to go and get some help. So they came into the emergency room and they said, the doctor said, go ahead, give it. Well, the father said, I have the factor and the equipment. Can I do it for him? I'm like, you do it at home. Why not? Can I watch? I'm telling you, this father and this son did an amazing job. The son picked out the vein, he held the butterfly, the father washed his hands, he took powder with liquid, mixed it up, pulled it up the syringe, primed the tubing, and it was just beautiful. It really was. If they're at home and they have bleeding issues, usually, they'll just go ahead and give it, call the doctor, and they do give it. So it does stop the bleeding there. So this kid fell down and he has bleeding, maybe going on into his knee or toe or wherever it is. What do you do? What should this child be taught? He needs to be taught. You think you're bruising, you need to rest. Stop. Slow down the heart rate, right? And then ice it. That constricts vessels, decreases bleeding, compress, same thing, and elevate it so it's harder for it to bleed. But why the P? Well, a lot of times we find this out when they're toddlers. What do toddlers do? They're everywhere, all the place, falling down, wobbly. They're going to bump into coffee tables and things that are sharp, and they're going to cut themselves. So pad the coffee table, remove the sharp items, whatever. Protect, protect, protect. Because we want to make sure that we don't get all of these bleeding issues and these children get, crippling problems in their joints and end up in wheelchairs when they're done. So children can live really a basically normal life. Again, it's just being careful and knowing what to do when you get bleeding going on. Yes, there's a gene coming out. It's not completely there yet. So immune thrombocytopenia purpura. This is purpura, P for platelets. It is a condition that's an acute. It can be cured or it can be turned around and platelets become normal, but it is caused from some sort of infection or upper respiratory infection recently. And all of a sudden, this child is going to appear with bruising and purpura. And the parents are saying, this kid doesn't go out to play. They're on the iPad. Why is he bruising? And or they come in with epistaxis, and we'll be looking at it. So, how do we treat it? First of all, we're going to do something to boost the immune system. We're going to give IVIG and we're going to give anti-D. When they're admitted, they will be admitted initially to watch them and see if the therapy is working and to monitor their platelet count, right? So when they're in your care, you need to teach them bleeding precautions, soft toothbrushes, no razors. You as a nurse, you're not going to do a venipuncture unless you absolutely have to, because they will bleed. Also, you'll be monitoring their blood counts, their platelet counts, watching it go back up. And this says sometimes, but you give steroids on these kids. Now, I mentioned epistaxis is one of the things that shows us sometimes bleeding coagulopathy problems in children. I've seen them come in with, epistaxis and find out they're ITP. And then, of course, then we can treat it. But this is one of your NCLEX questions. You might get it. So a kid bleeding out of his nose, they're going to be freaking out. They're bleeding and they're going to die. And they're running around and screaming, oh my God, blood, 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 bleed, bleed, bleed. And their heart rate goes up and blood pressure goes up and they bleed more. So, first, calm them down, have them relaxed, sitting on mommy, wherever they want to be. Calm them down, okay? That's going to help decrease the amount of blood that's flowing out. Then you put them on your lap, thumb, forefinger in the soft area of the bridge of the nose, and then you lean them forward. Why do we lean them forward? Because if they're bleeding, we don't want them to swallow. So at least it can come out the mouth. After 10 minutes, if it's still bleeding, you need to get them to medical attention. HIV and AIDS. We mention this because mommies deliver babies that could be HIV positive. Also, we know adolescents tend to have some risky behaviors, and we want to know how to treat these things. So, if it's an infant, this is the big thing. At 22 weeks gestation pregnancy, knowing that they're HIV/AIDS positive, they should be started on a highly active antiretroviral therapy, antivirus, anti-HIV. Okay. And what is the goal of us doing this antiretroviral therapy? Why are we doing that? Well, we want to improve that newborn's immune function. And I'm going to tell you a story. There was triplets. There was 3 babies, 3 girls that were born. And the mother was HIV positive, AIDS. One baby had HIV, one had AIDS, and one had nothing. So there is a possibility of babies born to an HIV mother that are not HIV. So we know if we know that parent, that mother is HIV, we are going to start immediately at birth that antiretroviral therapy. We are going to give them what they need. Why? The goal, improve their immune function. Let's give them a little bit of something to help say, HIV, AIDS, go away. I don't want you. I've seen children born HIV positive started on these antiretrovirals at birth, and by 1 year, they auto-convert, nothing, no HIV/AIDS. So that's the importance. Improve their immune function, and it can work, okay? The most common opportunistic infection in children is PCP pneumonia. So again, you start seeing that, we need to act on it quickly. Now, when we have problems with the immune or with hematology, we know that we're going to be doing something to help them, giving blood or taking stuff, doing some sort of test to figure out what's going on. One of the big things we do is giving blood or any type of blood products. Again, with blood transfusions, know that if there is a reaction, that we have to immediately stop that infusion, okay? Usually what I see is with a transfusion reaction, our procedure and policy, vital signs before yang the transfusion, 15 minutes later, and then every hour thereafter. I have seen, this is the most common, 15 minutes after the start, they get a fever, usually 101, 102, that quick. What do? Turn it off, get the bag, put it back in the blood bag, send it back to the blood bank, call the doctor, and do whatever they say to do. Many times we'll do a bone marrow aspiration. Again, it hurts. There's this big, thick needle with a sharp point with a T on top. So it looks like a T. They take their hand on top and go into the bone, whether the sternum or the hip bone. So again, it might hurt. Always be honest and let them know it's going to hurt. So when both parents have a sickle cell trait, what's the chance of their child having it? The disease.
Isn't it 25%?
Yes, it is. Thank you so much. All right, let's go ahead and do our first Kahoot. How's that sound? Who wants to win? Emily, are you ready? I think Tara's going to win today. Watch this. Oh, that's a different layout. Anybody else want to come? They changed the format. That's sort of cute. All right, let's go. What is priority treatment for a newborn of an HIV positive mother? It froze. So again, when we're talking about a newborn born of an HIV mom, our goal is for that child not to get it. And the only way to do it is to improve the infant's immune system. What is HIV? It's a virus. So antibiotics aren't going to work. It's a virus, okay? What kind of hematocrit would someone have with sickle cell? Why? So remember I said sickle cell children, they have it lower because sickle cells die faster. I've said if I have a child with sickle cell crisis coming in, if they have a hemoglobin of 7, I'm happy because usually they're 6 and 5. They're very low. What is the nurse's priority with a child with sickle cell disease who is currently experiencing a crisis? So, do you want to treat the symptom or treat the cause? And the answer is the cause is small blood vessels. So you want to dilate them. So IV bolus, normal saline. Now, yes, I have the morphine or whatever PMED in the other hand for the symptom, but if we can dilate the blood vessel, get those cells moving, the pain's going to go away. What is the reason children with iron deficiency anemia are easily tired? So, iron deficient anemia means you don't have enough hemoglobin, okay? You don't have hemoglobin red blood cells what do red blood cells do? They carry oxygen and iron. If you don't get nutrients, you don't get oxygen, there's nutrition, nutrition, nutrition. There's nothing in the tank. They're going to be tired. A multi. The nurse is teaching about a newly prescribed iron supplementation. What should be included? So remember, iron needs to be digested and broken down in the stomach with a stomach acid, and orange juice helps with that acid so the body can use it. So empty stomach before meals because it stains the skin and the teeth. We want to give them it through a straw. Also, make sure you tell the parents the stools are going to turn black. I've actually seen parents run out to the nurse's station with a diaper with an iron stool saying, "Oh my God, something's going on." So please tell them. Aplastic anemia includes a depression of which blood cells? Remember, A is without. I told you it's the worst. Aplastic anemia is white blood cells, red blood cells, and platelets, and we treat it with chemo to get rid of it. It's a rough one. Most common type of anemia is, and that's iron deficient anemia. And we know we can correct that easy. What causes pernicious anemia? So pernicious anemia is the intrinsic factor, it's B12. And this is, again, we can treat it by giving them B12. What is a symptom of B12 deficiency? I've never seen it, but it's a red, sore, beefy tongue. What symptom is the single most common symptom of anemia? And of course, it's fatigue. They have no oxygen, iron, they have no reserves, and they're just going to be tired. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Thalassemia. Remember, this is these cells that burst quickly and they spew the insides out into the vascular. It's going to be, they lose their iron and they put all of that iron out in the body. And iron is a big, big risk for seizures, and it can cause death too. So it's hypoxia and iron overload that needs to be treated. What, what lab values will you see with hemophilia? So what you're going to see is the PTT or APTT, if that's what you know it by, is prolonged. But the other bleeding things, PT and platelets, they're normal. Now you've got to figure out what factor it is in order to replace it, but at least you know you're dealing with hemophilia. What is immune thrombocytopenia purpura? ITP. ITP for platelets is decreased platelets, usually following an upper respiratory and infection. Platelets are low. Thrombocytopenia can cause these symptoms. ITP is low platelets. What do you see if you don't have enough platelets? What you're going to see is bleeding somewhere, whether it's little purpura, whether it's ecchymosis. The one thing I've always seen, it's usually the diagnosis and why we find it, is epistaxis, nosebleeds. A multi. The child with hemophilia has fallen and the knee is swollen and painful. Treatment would include so if you're bleeding, you're going to do that rice. You're going to rest, ice contain, and elevate. You're not going to exercise it, which creates more. Hot packs will dilate it and more bleeding will go on. What is the priority nursing action for a suspected blood transfusion reaction? If you have a blood transfusion and you spike that fever in that first 15 minutes, and I'm telling you, it's the most common one I've seen, is the fever. So we know, turn it off. And then what do? Put it back in the bag, send it back to the blood bank, and let the doctor know. A child is admitted with neutropenia. Which nursing action takes priority? Well, what is neutropenia? It's low white blood cells. If you don't have white blood cells, what's your concern? There's nothing to fight infection. So, what's your priority? Hand washing. Hand washing. Those isolations, no. Simple hand washing is your priority. When distraction is used, it helps. I put some things from last week that are important concepts to make sure you know them. I mean, I've done crazy things for distraction. I'll start dancing, I'll put on music, I'll start putting stickers on their forehead, all different things. Because when you take a child and make fun and play, they don't think about what's going on around them. And that's what you want to do. I went to work and played every day when I was a nurse in the ICUs, yes, but I got to play because distraction really works. What assessment question needs to be asked to a child with possible rheumatic fever? This is a question from last week, but an important concept. What is rheumatic fever? It's a bunch of symptoms. This is a sore throat, it's a rash, it's swollen joints, and it's that weird chorea movements, and it's from a strep throat that was either not treated or not completely treated. How do you take care of rheumatic fever? Well, it's due to a strep infection. So you give long-term antibiotics. Everything will be good except for the heart. Signs and symptoms of asthma. Another one from last week. Remember, asthma is when an allergen hits the lungs and it bronchospasms. So they start coughing like crazy and they're short of breath. And remember, air gets stuck in. So it's that wheezing, trying to get the air out. A multi. What symptoms should be reported to the healthcare provider for a child with sickle cell disease? Now, you've got some normal things you know, but there's serious ones that really need to be told to the doctor quickly. The big things that you need to be concerned about is headaches and chest pain. It could be a stroke or it could be a pulmonary embolus. Those are big emergency concerns. It is normal to have sores that might not heal or swelling of the hands or feet. Those are normal things that we look for. The other two, they're priority. You need to tell the doc. What are the odds two sickle cell carriers would have a kid with sickle cell? 25%. So they have a trait, okay? They have children, 25% will have it. Position for a lumbar puncture for an infant or a young child. That was weird. They've changed the format here. I'm sorry. Hodgkin's or non Hodgkin's, diffuse cancer of the lymph tissue. Now, I put this in here, it's cancer, but this is a question commonly missed by students. So I'm heavy hitting it here. What is diffuse all over the place? Which means you can't see it. It's in there somewhere, little pieces. And it's called non-Hodgkin's. Now, let me tell you how you're going to remember this. I'm going to tell you 3 times. I want you to remember it. Hodgkin's is a Hodge, it's a lodge, it's a house. You can see it, you can touch it. These are non-tender, non-painful lymph nodes above the shoulders, supraclavicular, and you can see them. And these big nodes, Hodges, lodges, house, swell so much that it starts pushing over on the trachea. Okay, that's Hodgkin's. You can see it, it's big. Non Hodgkin's is not a house. You can't see it. So it's all over. It's diffuse. Try to remember that one. A Wilms tumor. Again, I'm going to go over it again on next part of the lecture. But again, it's a concept frequently missed, and I want you to know it. I've seen one in my career, and I'll tell you when we get to it on the PowerPoint. It was an interesting way that I saw it. So Wilms tumor is an encapsulated mass in a kidney. It is a renal. It's a very fragile tumor of very young children, like ages 3 to 5. I see them. A child with a Wilms tumor. What action by a nursing student causes faculty member to intervene? What's not right here? You got this big mass on the kidney in the abdomen. The problem with a Wilms tumor, it is extremely fragile. And if you touch it, manipulate it too much, pieces will break off and it will metastasize. They do not even do a pre-op biopsy of it because it'll leave a hole and it will let metastasis come out. So we do not want them touching an abdomen, whoever. Even changing diapers, you got to be careful. Absolute contraindication for nasotracheal suctioning include which of the following? Again, giving you stuff from last week, concepts I want you to know. So anything in the mouth is going to cause swelling, right? So if you already have croup, which is inspiratory, create more swelling, it's going to turn to epiglottitis. If you're already epiglottitis, you're not going to breathe. And that surgery, TNAs, tonsils, again, you don't want to create bleeding. Iron dextran is given via which route? My first ever IM injection as a nurse was on a 40-year-old woman, iron. Can you imagine your first IM as a student? I was scared. It's called IMZ track. So I had to know this, go in first ever and pull up the skin, give it, take it out. And I call it a lock and load. I was very blessed. The lady told me I did a great job. I said, that's my first ever injection. She's like, you did a good job. Multi patient teaching for administering liquid iron. I'll ask this again later on. It's an important concept. Sorry, let me go. I can't go back. They have changed this. Let's try. There we go. All of a sudden today, earlier the format wasn't changed and now it is. I apologize. So giving liquid iron, remember, nothing in the stomach. You need the stomach acid. If you give orange juice with it, it helps with the acid through a straw because you don't want the teeth all brown. And please tell the parents that the stool's going to turn a color. Okay. I don't understand. I apologize. I don't know what's going on with the goats. Okay, I guess you just have to read them. I don't know what happened the way the format's going on. So, what cancer may present with painless, firm, and enlarged cervical nodes? And again, the answer is Hodgkin's lymphoma because it's a house, it's a lodge, it's something that you can feel, you can see, you can touch. Here we go. Thank you. A multi. When teaching about sickle cell disease, you would include what? So, sickle cell disease is a clog up the blood vessels because those sickle shaped cells do not want to flow nice. So, what are you going to teach these children and these parents? You're going to do everything to keep those blood vessels big and open and plump, right? So, take pain medicine if it starts to hurt early, or else pain medicine won't work. If you're outside, dress warmly, right? Drink fluids like crazy, and any immunosuppressed patient seek medical care if they have a fever. Thalassemia major is treated primarily with, this is Cooley's anemia. The big thing with thalassemia is these red blood cells die quickly and spew oxygen and iron into the blood system. So we are no cells. So we treat it, we're going to give blood transfusions. They need the cells. The body's not making them. What is the most common opportunistic infection for children with HIV? So it is PCP pneumonia. The second one is actually Candida or yeast. That's the second one. They always put them on some sort of anti-yeast, nystatin or something. They always have that tongue that's going on. What happened here? Okay. I don't know what's going on with the system today, but here we are right now. I'm going to send it to you again. There's a couple more questions. So Miranda, good job, Miranda. And Jennifer and Tara. You're sitting here playing a game that's always been one way for 6 years and it changed the format. I do not know what happened, but I appreciate your patience. All right, let's go on and do the rest of the PowerPoint. So, cancer, children and cancer. Let me premise this with children with cancer, and as a nurse, working with children that have cancer is a very difficult, very emotional place and area, but it's also extremely, extremely rewarding. They have today the need for pediatric cancer nurses. They pay you once you have experience and are chemo certified. They have these $25,000 bonuses, sign on bonuses for nurses like this. Something to think about if it's something that you want to do. I'm even traveling like that. If you're chemo certified, etc., you'll be high demand. So, cancer in children, most of them are the blood stuff, the leukemia and the lymphomas. So, what is leukemia? Well, leukemia is about the white blood cells, and cancer attacks them so you don't have an immune system. And then it also attacks red blood cells and platelets. So now you're infectious, you're anemic, and you're bleeding. This is all leukemia. It is more frequent in boys, and it's ages 2 to 5. They're young. So it's very difficult for parents. Do you know that Down's children are at higher risk? Poor guys, they already have problems with congenital heart disease, right? Now they also are at more risk for leukemia. Why do I mention this? Part of the problem with leukemia is bleeding problems. So you get a child who's a Down's child who has bruising all over. The parents are saying, I don't know where these bruises are coming from. I mean, most people would say, oh, they're just Downs, they're clumsy, they're more awkward, causing the bruising. But it could be leukemia. So it's one of the things to remember. A Down's child with bruising could be leukemia. Leukemia is the definition an unrestricted proliferation of immature white blood cells in a blood forming tissue. So your white blood cells are with cancer, so you don't have white blood cells. You don't have an immune system. So, how do you evaluate it? I actually had a neighbor. She was a girl. She was older. She was a teenager who ended up with ALL. And she went into the emergency room with a complaint of fatigue, fever, flu-like symptoms, bruising on her knee, and bone pain. When they did a CBC, they found that she had leukemia. Those symptoms is what they saw. So you go in, you get diagnosed. We're seeing that they're the smear, we're seeing the cells there. We know that we're dealing with leukemia. What's the next steps? Well, they're going to do a lumbar puncture. They're going to check that central nervous system, making sure it's clean or not. They're also going to do a bone marrow biopsy. Let's look at the way the cells are being produced. Remember, it hurts. Make sure the child knows that you'll do everything to make it as easy as possible. So we've been diagnosed now. We've done all the checking everywhere. Now we've inserted a central line. Usually it's a port. And the reason why we use a port is it's underneath the skin, usually upper right, left, or middle chest. And we take and put a needle in it and we access it every time they need to do blood or give IVs or whatever. So you don't have this thing hanging out so the kids can't pull on it like a central line. Okay. All right. So once we get that put in, they're going to start chemo. 4 phases. The first phase is called induction therapy, and it's only 4 to 6 weeks, but intense chemo. Two, three types, whatever the doctor thinks, according on the cancer. And in 4 to 6 weeks, our goal is remission. And then you're saying, so then why do we go on giving more? Well, we got to make sure the central nervous system is okay. And we've got to make sure there's no little sneaky little cancer cells, those little outliers somewhere. So what we do is we give it more to be sure, and then we put them on a maintenance. Now, one of the treatments for leukemia, if the chemo and whatnot don't work, is a hematopoietic stem cell transplant. And there's two types. There's an autologous and allogeneic. Now, the thing about stem cells, you don't need a blood type. You don't have to be an A positive or an O. It's anybody, okay? But the best person to have is your own blood. So autologous, automatically mine is the best. It is usually like a cord blood that they have saved, okay? Allogenic is all the others. And of all the others, allogenic siblings are your best of the same parents, okay? Our biggest concern is graft versus host, which is rejection. So again, prepare the kid, be honest, let them know what's going on. And this child is immunosuppressed. They don't have platelets, they don't have hemoglobin, they don't have any sort of infection immune system to help with infection. So there's all sorts of complications. And again, we're going to be given chemo. Now, what's the outcome? How do they do? Now you're giving chemo, you've done all this stuff to them. It depends on what was their white blood cell when they came in. Remember, leukemia attacks the white blood cells. So normally, white blood cells are what? 7? That's a normal number, right? When you see leukemia, it's 0 point something, 0.1, less than 1. I've seen 0.01. Now, because of that initial white count of so low, outcomes are not as good as one with a little bit more white blood cells when we start. Also, how old were they? The young kids actually do better. Now, what cell? We have AML and ALL. Lymphocytic, myeloid, ALL is the easier one to cure. Girls do better than boys. And why do we worry about karyotype, blood types? Well, during this, the hemoglobin's low, platelets are low. They're going to be getting infusions. If you have a rare blood type, it takes longer to get the blood. Again, delay in care. So what do we do when we're talking about, cancers and the treatments? Well, we could do surgery, chemo, radiation. What child would get radiation? Not all of them. It depends on the age and the type of cancer, younger children getting radiation. I mean, all of them get the chemotherapy, but radiation is limited to some children, not all of them. Sometimes you do chemo, sometimes you do radiation, sometimes you do both. It all depends. So our goal is as early as we can detect it, we do better. The symptoms, just like my neighbor who went in, to the emergency room. She had pain. She actually was knee pain she went in with. She felt horrible, had a fever, flu-like stuff. She had bruising going on she didn't know about. And she just felt horrible. You might see weight loss. I might see lymph nodes up, and it does affect the vision. Now, one of the side effects of treatment in chemo is you're wiping out your immune system. You're killing, yes, the white blood cell cancer cells, but you're also killing some more of the good white blood cells. So, one of the things that we are going to monitor is your neutrophil count. That is the white blood cell we worry about. What is a normal neutrophil count? It's about 2,000. That's about a normal, somewhere around there. Children that have 500 or less are your ones that are at risk for septic shock. Now, we mentioned this with chemo and children, getting it, which we know their counts are going to be low. But any patient, children's, adults, it don't matter. Any patient with a neutrophil count of 500, and then the nurse assistant tells you, oh, they got a fever of 101. This is your priority patient if you're given a block of patients. Neutrophil counts low with a fever, you're set up for septic shock. So you'll be doing cultures and you'll be starting antibiotics quick. This is your priority patient. So chemotherapy does a lot of stuff, right? Radiation does a lot of stuff. So there's going to be bleeding. So we're going to be given platelets. We're going to be given transfusions. We need to have that child be careful. I mean, kids play, but you have to be careful. They're not going to be bruising, more than normal. They're going to be anemic. Remember, this chemo not only takes care of cancer, it takes care of normal red blood cells. So again, they'll be anemic. Do all those precautions. They're going to be fatigued. So be careful with physical activity, cluster care, and all those things. They're going to be nauseous. Make sure we give stuff before we give the chemo. They're going to have problems with eating. They're not going to feel good. Sometimes they have a lot of mucosal irritation, mouth to anus. It could be all inflamed. So we have to really, really be careful on nutrition, right? So how do you monitor nutrition? It's as simple as a weight. If they're younger, of course, developmental stuff, but basically height and weight, and then we'll just monitor other lab works. So what sort of diet would we think that these children would need? They don't want to eat, but you need nutrition. So high everything, high protein, high calorie, big fat, all of it, because we want every bite to make a difference. As I said, their mouth to anus can be really sore. If it's in the mouth, make sure that we give them bland foods. It's not going to burn them. Of course, those toothbrushes, make sure they don't hurt them. And of course, if it's down to the anus, we can do sitz baths. Another problem is because they get pain management, because they do have pain, they're going to have a problem with constipation. They have low platelet counts. They're apt to bleeding. So if we don't help them get their stools out with a stool softener, they're going to push so hard they could have a stroke. You got to be careful with that. They can be bleeding in their urine, and we know hair loss is something that they come up with. Again, what can you do to help that child deal with the hair loss? I mean, many parents, fathers, brothers, they'll shave their heads off. I make cute little head ribbons and stuff, and I wear, and we be twins for the day. And then they feel more special. We know steroids can have children swelling up. Again, be aware of it. Again, make sure their clothes fit properly. So getting these kids ready for procedures. Now, bone marrow aspirations, whatnot, they do sedate them. Absolutely, because it is quite a rough procedure. Just hearing the noise of as they try to get into the bone, again, they're sedated. Always be honest, let them know what's going on, and make sure that physician uses lidocaine, numb it up good. Pain management's really important, and we need to use doses. I mean, if they're in pain, increase the doses, they need it. Health promotion, they need dental care. One of the questions that always comes up is immunizations. Can they get it when they are in treatment? Well, yes, but anything live, no. The other thing I want to mention about live virus immunizations, you cannot take them if you're on steroids. Any normal patient, healthy patient on steroids, they are immunosuppressed. They cannot get live vaccines either. It's always a question about that. Also, varicella is a big, big, horrible disease for children that are immunosuppressed. Make sure they have that vaccine. Here we are, Hodgkin's, non-Hodgkin's. So this is the second time or third time I'm talking about it. So lymphomas, it is a swollen lymph gland. You can see it, feel it, touch it. This is Hodgkin's. It's painless. They really don't feel it. What they do with Hodgkin's is they look at it, see it. Usually it grows so much, it starts coughing, it obstructs the trachea, and that's usually what brings them in. The fever, anorexia, it's pushing, they don't feel good with it. They do a biopsy. They find Sternberg Reed cells, and then they do radiation, chemo, and remove it. Okay. Non Hodgkin's is not a house, it's not a lodge. You cannot see it. It's something it's diffuse in the body. Okay. We do about the same sort of treatment, surgical, radiation, if we can find one of the masses, and again, surgery. We also will do chemotherapy on these children. Now, nervous system tumors, brain tumors. Think about something in the brain growing, pushing pressure in the head. What are you going to see? Well, it starts out with a headache and then vomiting that get progressively worse. It could go on younger kids, hydrocephalus. It could also push the eyes and make them twitch, go into what I call seizures, nystagmus. It can affect your gait, ataxia, and because the pituitary gland's inside there, and it could cause pressure there. It could cause diabetes insipidus and growth failure. And that's the pituitary gland. We'll talk about that next week. So, how do we diagnose it? You've got a child who's got a headache, who's vomiting, and it's getting worse over time. We're going to start out with a good old head x-ray, and then we'll go further, CAT scan, MRI, etc. So we've got a brain tumor, and we had to do surgery. We've done radiation, we've shrunk it, we've done chemo to make sure that we've got this as small as possible and contained. Post-operatively, there's many things nurses have to think about. How high do you raise the head? Is it 30 degrees, 45 degrees? Do you turn the child on the side with surgery or do you turn it off? These are things that are important. And the biggest thing is fluid regulation. If you give too much fluid, cause swelling on the brain, it could cause problems, okay? Now, neuro or nephroblastoma, very rare, but we mention it. It starts with a tumor in the abdomen that gets bigger and crosses midline, and then it metastasizes to the brain. Usually, we don't see it until it metastasizes, and you'll see things like periorbital edema or eyeballs bulging, exophthalmos, or you're seeing some neurological something going on. We're going to do chemo, we're going to do radiation, but it's already metastasized. Outcomes are not great at all on that. Bone tumors, osteosarcoma. When we talk osteosarcoma, we're mostly talking about adolescent boys and bone cancer, osteosarcomas on their femur bones. What they see in their symptoms that bring them for medical care is this limping. They're limping, and it gets worse over time. And then it starts to get pain. And then they can't hold things, and their leg gives out because of the pain and that mass in the leg. So, what do we have to do? Well, we find out this pain and we look at it. We do an x ray, CT, MRIs, all that thing. Look at cancer, got to check, the CBC. And we could do a biopsy on this one. They're going to do radiation, chemo. And the ultimate they need to do is remove the bone that has the cancer. So if you're talking the femur bone, which is adolescent males, the whole upper leg has to be gone. So they can do two surgeries. The goal is to be able to take the lower leg and salvage it. So salvaging the limb, they take the lower leg and put it up in the hip joint, turn it around, because they can use it for a prosthesis. So goal on osteosarcoma is to salvage that piece of limb. Or if they can't, it's going to be a complete amputation. You can't take that tumor off the bone. It don't work. The whole bone has to be gone. Now, Wilms tumor. I promised you a story. 3-year-old boy came from Haiti after the Haiti earthquake. Our hospital had gone down there as a rescue team, and they found this child that had this tumor in his abdomen. And they had these religious groups or somebody or whatever, and they got this child over to Miami Airport. They had a religious group, picked this boy up and brought him to the ER, to my triage desk, and said, "Here he is." And I said, "So what's wrong?" And they said, "I don't know, but here's the papers they sent." When I look at the papers, they're all in French. So now I have a 3-year-old boy from Haiti sitting on my stretcher, and I don't know what's wrong. And I've got to place him somewhere in the emergency room. So I've got a child who only speaks French. I parlez-vous un petit peu. I speak such little French. So he's a 3-year-old boy. He's scared. I had to get down on his level. I had to break the ice so I could touch him, feel him, and assess him. And I was able to do that. When I went down to his abdomen and checked it, I found like the size of my fist tumor in the left lower quadrant. And for some reason, I knew it was a Wilms tumor. And immediately I put on the chart, do not palpate abdomen. These tumors are extremely fragile, and the manipulation breaks off pieces and causes metastasis. They don't do pre-op, pre-surgery biopsies because it'll leave a hole and let it escape and metastasize. So what we do, sometimes they do radiation. Again, it depends on the age, et cetera, of the child, if it's beneficial. And then they do chemo and they do surgery. Surgery is done pretty quick. Our biggest concepts here: Wilms tumor, a renal tumor. Do not palpate it, okay? It will make it spread. Also, where are the kidneys in the body? They are in the back, right? So when we open the abdomen, we got to go through all of these intestines to get in there. So post-op, can you imagine what we're checking? Bowel function, because a lot of them go into ileus. Their intestines don't like that manipulation. We're also going to monitor, of course, urinary output and always infection. Retinoblastoma. This is in the retina, a tumor. I've seen one. I think it was like 8 or 10-month-old little girl. And if you look at that bottom picture, I saw that white thing. Now, we call this a cat's eye, a glow. Ever see an animal out in the dark and there's a light and it shines and you see these glowing eyes. I see frogs, those things. You see those eyes there? That's what it looks like. Now it's cancer. So we have to do a radiation for these children to shrink it down. Now, that radiation mark, that purple little arrow there, do not ever wash it off until they're done with treatment because that gun has to go directly there in order for it to work properly. They take the eye out. Now, one of the things as we're assessing these children is that we need to know, was there any previous conditions, things going on with the eyes, any symptom, rubbing, infections, anything? Those are things that we do need to ask. Now, germ cell tumors, testicular cancer. You know, men should do monthly testicular exams, just like women do monthly breast exams, right? Looking for lumps. I have a story. 18-year-old boy comes into the emergency room. I'm in triage and complaining of testicular pain. When the nurse who was in the room with me examined him, his right testicle was the size of a softball. And we were like, oh my goodness. Sent him back to the ER and they did an ultrasound and they did an abdominal x-ray. And the child already had metastasis. 3 months later, that child died for testicular cancer. Liver tumors, livers grow back. It's one of those neat little organs, probably one of the easiest cancers. You know, cancer survivor is better than ever. If I talk about 50 years ago when I started nursing, not many survived. They didn't have all these medicines. But today, this is saying 80%. It's probably even higher than that. They're coming out with a lot of good stuff. And I love these pictures on social media, cancer free, because I know what they've put up with. All right, who wants to win this one? Lauren, are you going to win this one? Maybe. How about you, Miranda? Yeah. Let's see what this Kahoot does this time. That was crazy. I'm going to run to the ladies' room. All right, let's get going. Let's see if it works this time. A child is admitted with neutropenia. Which nursing action takes priority? What is neutropenia? It's low white blood cells. If you don't have white blood cells, what are you worried about? Infection. So, what's priority here? It's all about washing your hands. That's always priority. Which symptoms would a healthcare professional expect to see in a child with leukemia? Remember, leukemia is a problem with white blood cells, but also your red blood cells and platelets are also affected. So, what would you see? Bruising, fatigue, and usually there's a bone pain with it. Which child with a Wilms tumor, which action by a nursing student causes a faculty member to intervene? What do you know about a Wilms tumor? It's a kidney tumor. And the problem is very fragile. And our concern is spreading it all over, right? So our concern is if they're palpating it, we're going to be causing manipulation and causing metastasis. I mean, even changing a diaper, you got to be careful with. Your child with ALL has had recent lab results, and the platelet count is 10,000. What's your action? Any patient with platelet counts of 10,000, what is your concern? What do platelets do? Platelets are all about bleeding. It's part of what you need to stop bleeding. So they're on bleeding precautions. Remember, anybody with low platelets, you have to worry. A child with ALL has a fever of 100.5. What should they do? Any immunosuppressed patient, adult, child with a fever, what should they do? Let's put it out there. Open it up. If you're immunosuppressed, you don't have an immune system. So you have a fever, is a big deal. Get medical attention quick. Your child's having a bone marrow aspiration. What should you tell the child? Remember, anything you do to a child, you need to be honest. If it's going to hurt, let them know. Don't let them all of a sudden scream. Most common clinical manifestation of a retinoblastoma. Remember, that's the cat's eye. It's a tumor in the eye, in the retina, and it tends to glow in the dark. You'll see them shining. I've only seen one. Your child's been diagnosed with a retinoblastoma. What information is important? What do you need to know about that child? So, if you have a problem, you have cancer in the eye. I want to know what's going on with that eye. What's happened up to this point? Infections, blurring, rubbing, anything. I want to know because that can help with the diagnosis and treatment. A goal of surgery for a child with osteosarcoma is. So you have bone cancer, and many of these are in the femur, and they're that adult, that adolescent male. It's pretty hard diagnosis. So we have to get that bone out. But our goal is to take the bottom part of the leg and put it up so that we have a place to put a prosthesis so they can be ambulatory. A child's complaining about those skin markings for radiation therapy should be told what? That purple little thing on the head or anywhere. I mean, that's where they take the radiation gun and they point it. So these markings are there because that's exactly where they need to put it the next time so that it's more effective. We used to have these washing them off parties and make it a big deal. What assessment question needs to be asked to a child with possible rheumatic fever? What is rheumatic fever? What's our biggest concern? And it is heart valve damage. So rheumatic fever is caused by a strep throat, whether it was treated or not treated. Again, if we get rheumatic fever and have all of the symptoms of it, if we get long-term antibiotics, everything will go away except for that heart valve. If it's damaged, it's damaged. If a child was to receive their own bone marrow, this is called a blank transfusion. Mine is automatically mine, autologous. Allogenic is all the others, and the best ones we know are siblings. What cancer may present with painless, firm, and enlarged cervical nodes? And that's Hodgkin's lymphoma. It's a house, it's a lodge, it's a hodge. I can see it, I can touch it. It's there. It's painless and firm and large. Remember, non-Hodge is diffuse. I can't see it, touch it, or feel it. A multi. Treatment of osteosarcoma includes so a stem cell transplant has nothing to do with osteosarcoma. That's more blood-borne sort of things. We need to get that cancer out of the body. So we either need to amputate it or we need to take the bottom part of the leg and salvage it. Our goal in osteosarcoma is to salvage the limb. Yes, chemo, radiation, all of that, but not stem cell. I mean, if we have to, we'll do amputation, but salvaging is what we want. A multi. Who are the best donors for a bone marrow transplantation? And bone marrow transplantation is a liquid that goes in an IV. So we know best donors are automatically me. I'm the best, but allogenic. All the others, siblings, are the best. Mom and grandma, they're not as high. Siblings are more. What would you consider to be neutropenia or a low neutrophil count in children? And remember, neutropenia and a fever equals danger, possible septic shock. That's your priority patient if you were given a load of patients. And it's less than 500. It should be about 2,000 ish, but less than 500. You have no immune system. A primary characteristic of a brain tumor is you got this thing growing in the brain, getting bigger, taking up space. What are you going to feel? It's growing. And the symptoms are becoming worse over time. Headaches, you're having not occasional, headaches become worse over time. Vomiting has nothing to do with eating. It's not like you eat and vomit. And good balance, you probably are going to be becoming more ataxic and not moving as well. The optimum treatment for an osteosarcoma is what do we really want? What is our goal? Do we want to hack the leg off or do we want to salvage the limb? And the answer, we want to salvage the limb. Now, removing the tumor and saving as much bone as possible, it's not possible. The cancer is the bone. You've got to take the whole bone. It's not like you see a piece of a tumor, you take it out. No, the bone, the whole bone must be gone. So if it's in the femur, we're going to either amputate the whole leg or we'll take the lower leg and use it as an area for a prosthesis. Last question. A child's receiving induction of chemotherapy. What does that mean? What's induction? It's the first 4 to 6 weeks, right? What do we want with that? Ooh, and we know that induction is we want remission. Number 3, Emily. Number 2, H. Number 1, drumroll, bing, bing. Miranda. Good job. Number 4, Jennifer and Tara. All right. So that is our class for tonight. Remember, this week you do have that case study or sim chart, whatever you call it, and NCLEX questions. Any questions with anybody? Good luck with your exam. Take care.